Okay, I've been challenged to share with you some thoughts on track and field athletes, but particularly about the shoulder, and I've also been given the challenge of following Jill Cook about on the topic of tendinopathy. That's a tough challenge. Fortunately, we're going to talk about shoulder tendinopathy, which she's actually acknowledged, and I think most people acknowledge there's actually not that much great research data. So I'm going to try to give you kind of a clinical approach and overview of shoulder tendinopathy in track and field athletes. And I do want to thank the organizers for inviting me to participate, but also if you look at the little pictures that we have advertising this conference, 3 out of the 7 athletes have a potential risk of shoulder problems. We have a javelin thrower, we have a hammer thrower, and we have a pole vaulter who's going to be lifting with his upper extremity. So it does happen in our athletes. Now, I have no particular disclosures. I do serve on a variety of editorial boards, and for this purpose, I actually serve as a visiting surgeon here at Aspetar and have done that for the last 3 to 4 years. So what are the key functions of shoulder in sport? It places the hand in space. So anytime that you have anything that you have to reach, throw, toss, catch, you're going to need great shoulder function. It has enormous mobility. And so the shoulder is the most inherently unstable joint. So your ball and socket of your hip is locked in. Your shoulder wants to be unstable. And in most functional range, not the extreme range of motion, but most functional range of motion, that's taken care of by your rotator cuff and your muscles that's keeping your shoulder stabilized. So if you have abnormalities in those functions, you have potential of risks of overuse or tendinopathy. It depends on the rotator cuff for scapular positioning. It depends on the capsulolabral and bone for the extremes of motion. It also creates the fastest motions in sport. And so when you're actually pitching a cricket ball or throwing a baseball or hitting a tennis racket, the rotational motions is up to 7,000 degrees per second in terms of throwing a baseball fastball. And so there's extreme loads that occur. So what are we seeing? Who is at risk of shoulder tendinopathy? Well, we're going to look at throwing sports, racket sports, martial arts, and lifting and power sports. But for the track and field positions, we actually think about javelin, hammer, discus, shot put, so all the throwing sports, and then anything that has a lot of lifting. And so we're going to have problems potentially in anybody who's doing upper extremity lifting, but things like pole vault is also going to place us at potential risk of repetitive chronic overuse, and so we have to pay attention to loading with our the loading being a factor leading to these problems. So how do they present for shoulder problems in our track and field athletes? Well, generally, they're not just going to show up. They're going to have a history of prior complaints, so you want to look for that history. It's going to probably be the most predictive value of having recurrent shoulder problems. Pain, and so rotator cuff pain, and I think Jill's focused on it. You want to be very clear about making this diagnosis. So pain is difficult to focus for the rotator cuff because it hides underneath the acromion. The biceps tendon, which can cause shoulder pathology, you can palpate to look for focal pain. But a lot of the time, this is going to be tested by eccentric loading. They're going to hurt when they eccentrically load, and it's going to be repetitive because of that loading. Some of the things that you've learned from Jill is actually very appropriate in shoulders in terms of how to help make this diagnosis. It's usually more a functional type of diagnosis of when they're getting the pain. They're going to have weakness. They're going to have. You can look for abnormal mechanics in their throwing mechanics. We'll talk about that a little bit. And one of the other things you'll see oftentimes with a throwing athlete is they start having decreased performance. So if it's a javelin thrower or a hammer thrower, they're starting to hurt. They actually have less distance. You wonder why they're becoming more erratic. They can't throw it as accurately or as far. Some of those subtle differences, your first signs are going to be maybe they're starting to have shoulder problems or any problem along their kinetic chain. So how do you confirm the diagnosis? You're going to look for this focal pain along the biceps. It's hard to actually make the diagnosis in other places, so you're going to have pain exacerbated with loading, particularly with eccentric loading. And so one of the ways I can tell somebody's moving around, if I'm looking for somebody with rotator cuff pain, it's when they put their arm up and they drop their arm. When they're bringing their arm down, that's if they start having that eccentric load, and that's when they have pain. I'm more concerned about rotator cuff pathology. Half your shoulder examination from posterior. Now I'm going to walk through some of these others. We'll show some of the pictures of different other exam pearls for you. Now, I give you this clue here. Kiram Khan helped us make these videos several years ago. They're now available on British Journal of Sports Medicine, so you can see all of the different shoulder exam videos if you want. So, pain with palpation, look for that over the anterior aspect of the shoulder. They may have resistance with Speeds and Jurgensen's tests will show those, but you look for that palpable things. You want to isolate the rotator cuff, so you can actually do these and think about the different functions of the pieces of the rotator cuff, your infraspinatus, your supraspinatus, your teres minor, and your subscapularis. So if you can think about how to isolate those tests, try to load them and see if that exacerbates their pain. So here you see this CAN test, which is the classic test for isolated supraspinatus testing. You're going to assess for weakness in that, but also if you can drop them, you start bringing them down an eccentric load, and that's causing pain, that becomes a problem. A belly press test, or also called an Napoleon test, basically you put the elbow out to the side, so you're doing an isolated internal rotation. You can actually do a lift off from the back. Some people prefer either one, but that's isolating your subscapularis. Again, if you can identify that against resistance, it may tell you that you're having a problem in those areas. Speeds and Jurgensen's tests, these are tests that you're looking for biceps tendon pathology, so you're resisting biceps extension or you're resisting biceps supination. You're putting a load on over the biceps tendon as best as you can. If you can get the pain here with associated palpable pathology, then you can be fairly confident that you're having rotator cuff or biceps tendon problems. Half of your examination of your shoulder should always be in the back, and we're going to talk about some of these pathologies potentially leading to you have to look at the kinetic chain, look at all of the things that can contribute. But for your shoulder exam for rotator cuff, half of your examination should be the back, and you're looking for things like dyskinesia. For this winged scapula, so if you have poor scapular function, your rotator cuff can't work right, your acromion actually is going to rotate forward, so it's going to close off the outlet that increases the risk of impingement, increases the risk of compression that Jill has also said is one of the key causes for potential rotator cuff arthropathy. Look for atrophy. This is going to be a sign of dysfunction of the rotator cuff muscles. In this case, you can see the atrophy of the infraspinatus muscle. And you really want to look for a shoulder function. So when I'm looking from posterior, I'm going to actually have them protract, retract, elevate, and I'm going to do that in 4 different positions. But actually, Ben Kibler has actually showed us this is really great. This is really great. I love this, and this is one of the way I actually clarify the differences between rotator cuff pathology and maybe other things. I'll do a scapular assistance test or a scapular retraction test. And what I'll do is, if they have pain with putting their arm up in front of them in forward flexion, I will hold back the bottom picture, retract their scapula, and have them repeat the test. If their pain goes away, then simply by controlling their scapula, I've reduced the amount of impingement that's going on, and now I know that if I just treat their scapular problems, my rotator cuff impingement or my symptoms around my shoulder will improve. So very good tests. Clearly, probably one of the key tests for shoulder pathology is not paying attention to the shoulder. Don't miss the big picture. Look at the entire kinetic chain. From the foot and ankle, that I think we're going to hear about with some perineal things. You're going to look at trunk and back, shoulder function, scapular stabilizer. So all of this delivery mechanism you have to look at, because each of the pieces are going to sequentially potentially load your shoulder. So if you're not turning well, you're not pushing off on the floor well enough, then you're going to overload your shoulder if that athlete is trying to get the same distance on his javelin throw. So poor power generation comes from the core, so poor transfer is going to lead to a significant problem. 60% of your kinetic energy is generated by the legs, so again, you have to have this transition, otherwise you're going to overload your shoulder, and repetitive overload is what leads to this tendinopathy and problems with the shoulder. So you want to do this thorough kinetic chain examination. I think I sat through Jill Cook's tendinopathy session yesterday, and she showed us how to evaluate people with serial hopping, watch their dysfunctions. I do single leg squats on stable and unstable surfaces, and just basically try to look and see if I can see any problems along the kinetic chain. All of the physiotherapists here probably do an even more intense evaluation of trying to evaluate that, but that's going to be key to evaluating this rotator cuff pathology. Diagnostic injections, I tell you what, most of the time I would agree with Jill that you should be able to make this diagnosis clinically. It's difficult to palpate the rotator cuff, but you can figure it out by all these isolated tests that we were showing you. However, sometimes it gets a little confusing in trying to figure out whether it's really in the shoulder joint itself or it's referring from the spine or somewhere else. You can do a diagnostic injection, and if they have pain relief, then you can be fairly confident that it may be bursitis, but it's something around this rotator cuff mechanism. Imaging pearls, I think that there actually is some great things that you can do with imaging. We had a nice talk earlier today about some imaging with stress injuries. I think there's going to be a difference between, can you image this with an ultrasound, which is great point of service evaluation. You can actually do this on the sideline. You can do this at the Olympic Games. It's hard to get them to send them off for an MRI scan. If I start saying they're resistant, they're not getting any better, then I personally probably get an MRI scan because it ultimately is going to show me the depth, the size of the tendinopathy. And in all honesty, for surgeons, actually it ends up making a difference. So if my rotator cuff is more than 50% thick, then instead of even maybe doing a debridement, I may ultimately have to do a reconstruction or rebuilding the rotator cuff or repairing the rotator cuff because it's more significantly involved. So the MRI scan can help me make specific decisions. So biceps tendon, where's the actual pathology with these shoulder pathologies? Biceps tendon, oftentimes at the insertion, it's related to internal impingement. May have some rotational issues, but oftentimes it's traction and internal impingement leads to the problem. This internal impingement, you can see from some of these pictures, and we'll see if I can make my laser pointer work. There we go. So when you get an abducted external rotator position, so a javelin thrower, anybody who's throwing here, what ends up happening internally, this is not actually pain underneath the acromion. This is actually you're rotated so far back that your undersurface of your supraspinatus is pinching on the posterior superior aspect of your glenoid. And so you get an undersurface compression or impingement that causes a gradual breakdown of the undersurface of the rotator cuff. That may be a compression source, but that repetitive loading probably leads to failure. Now, we've learned we've talked about different things causing tendinopathy, and is it really because of a compression phenomena or is it because of a vascular phenomena? Clearly, we know that in terms of the rotator cuff, circulation can come from the muscle, so our tendon value is here. It can come from the insertional site, so you can have some circulation here. This very area in the middle is the watershed area, which is the potential risk of potential devascularity because you have poor circulation. Now, that's actually also where we commonly see the tendinopathy form, usually on the deeper surface rather than superficial surface. As the person maybe goes through follow-through, you're going to actually compress the inner surface a little bit more than the outer surface. So you may have undersurface rotator cuff pathology. In an abducted external rotated position, you may involve the more superior surface. Now we know that rotator cuff pathology, most of the time with our throwers, is actually on the inferior surface. So the pathology is probably associated with some type of an internal impingement pathology. Now I would actually suggest you pay attention to another issue with all of your tendinopathies. And that is, I believe that your tendinopathy occurs because of chronic repetitive loading on the part of the tendon that's nearer the center of rotation. So if the rotator cuff is probably my best example. You have your rotator cuff muscle forces pulling tension to try to abduct your arm. You have your outer surface and you have your inner surface, and just because it's a circle, this is a shorter arc. And we actually studied this in the lab. If I pull tension on the rotator cuff, you're going to have increased loads repetitively on the shorter arc. And so that chronic repetitive load leads to overuse because of that loading that probably leads to why we can explain undersurface tendinopathy first. Now that may be associated with compression, it may be associated with vascularity, but I do think if you look at most of your tendinopathies throughout your body, they're actually going to primarily be on the surface that's more close to your center of rotation first. Now you can get classically external impingement, which is here is an AC joint, can pinch on the rotator cuff, but that's actually not so near the insertion point. You can get an acromial morphology where you have a spur that causes impingement, that causes compression on the superior surface of your rotator cuff. Our problem is actually on the undersurface. So what we want to pay attention to in terms of our athletes is we want to monitor our loads for our throwers. This is going to be to try to decrease their potential risk of problems. We want to evaluate their throwing counts or pitch counts, how frequently they're having repetitive practices, the intensity of their practices, the type of training. So if they're actually doing competitive throwing and workouts, that's actually loading your rotator cuff, causing potential overuse. And then ultimately, if they start having findings, you have to want to make an assessment whether they actually need time off to try to get things to resolve. So the fundamentals for treatment for prevention of mild to moderate shoulder tendinopathy, you want to control the pain first. So they can't do the exercises that are going to retune their rotator cuff unless they have decreased pain. So I may use some type of Tylenol, I may use nonsteroidals. I don't really like nonsteroidals, but Tylenol, ice, something to try to decrease their pain. Jill has shown us that we can actually do isometric long holds, 45 seconds times 5, in other areas of tendinopathy and have a very positive effect. So I think personally, I've learned that here, I'm taking that home, and I'm going to be using that on all of my throwing athletes and see if I can do these 45-second holds to see if I can quiet their rotator cuff to then allow them to do their rehabilitation. You then want to restore and monitor the soft tissues. So you have to figure out what the problems potentially are, and this is potentially going to be loss of total arc of motion, and we know this. Our professional baseball players, the Chicago White Sox, what they'll do is they monitor their throwing athletes every week. And when they'll actually assess their total arc of motion. Once they've lost their total arc of motion, they'll miss a rotation. They won't be allowed to compete until they go through therapy to regain their total arc of motion. Why did they figure that out? Because they had higher significant total loss of time from play when they developed shoulder problems. If they go through this monitoring program, they were able to return the people to play much quicker. So you want to continue to work on stretches, optimizing the soft tissues, pec minor stresses, dry needling, Graston, all potentially can provide significant benefit. This was one of our athletes at the Olympic Games who came in, had chronic rotator cuff issues, actually had a subacromial injection before she came to the Olympic Games, and I tell you what, when I saw her, there was no way in the world she was going to compete at the Olympic Games. Except our physiotherapist said, hey, do you think we can dry needle her? And so he does this periscapular dry needling, decreased her tension all around her shoulder, and actually she was able to compete because she actually had a better shoulder function that allowed better motion around her shoulder. Working on all the motor balance, but you want to balance front and back, internal, external rotators, protraction and retraction, total scapular control, all going to be very important to try to optimize the function of your athletes. Optimizing dynamic stabilization, functional body awareness is going to be key. You can do this through rhythmic stabilization, so actually not only just these isometric loads, but you're going to want to load them in internal, external rotation, abduction and internal rotation, so you can see Kevin Wilk here. This athlete's not just an external rotation, he's actually perturbating front and back, so he's actually loading that and giving him, and here he's on the balance board, he's perturbating him so that he actually can respond to those different treatments. Another potential, you can use some of these types of devices. See if they'll work that. You can use those types of devices which actually will, let's see if we can make them work. So they can work through function to, again, now they can do this at home rather than having a physical therapist working on perturbations to try to get their cuff working a little bit better. Always want to assess the entire kinetic chain, glenohumeral, scapulothoracic motion, pelvic girdle, hip range of motion, all of those are going to be very important. And then ultimately you're going to want to partner with the coaches. This is going to be very key because I will tell you, as most of the physical therapists, you may be great at the sport, and as a doctor I think I know something about the sport, but it's actually partnering with communication with the coaches to say, how are they throwing, are they doing very well, and how can I improve their kinetic chain and biomechanics to try to get them back. So the coaches are going to be a good friend here to make sure that they're very functional. Controlling inflammation is the last of the pieces, and promoting tissue degeneration during an active phase. You want to use cryotherapy. Tylenol I prefer. Non-steroidals I do think have some negative effect potentially on healing, so I tend to avoid them. I do avoid steroid injections unless it's really to calm things down to allow rehabilitation. If you're going to use steroids, you have to be very careful because you may have to use a TUE in competitive sports. Collagen synthesis, you can use increasing blood flow to try to increase rotator cuff healing of the muscle. It may not really affect the tendon. Eccentric loading has been universally accepted as the appropriate place. And nutrition, PRP, stem cells, all quite questionable whether there's evidence to support that it makes a big difference. Last thing I'll share with you is in terms of surgical outcomes. We'll just kind of fly through this. Bottom line is it a good idea for rotator cuff tendon pathology for me to jump to surgery and fix them that way? And unfortunately, if they had a complete rotator cuff tear, their return to play is actually quite dismal. And so this is a study by Jimmy Andrews. 1 out of 16 athletes in professional baseball returned to play. Another study showed only 50% were able to return to play. Here's another study, 76 were able to return to play, but only 55% were able to return to some high level of outcome. And so ultimately what we can see from most of these swimmers, baseball players, other different sports, that actually the best thing for us to do is actually probably not to jump to surgery, unless we have to. We want to make the accurate diagnosis, monitor them carefully and looking for all those associated factors, particularly kinetic chain, rotator cuff muscles, scapular stuff that's going to make a difference in terms of their function, early treatment when possible, and then avoid surgery as a resolution. Thank you.